Good day, my dear students. We shall continue to rip through hematology. These are my references, and I hope you are able to guess what is there for today's class. It is bleeding disorders. As advised, please do not change your book. You mark notes in your book itself. You can have a workbook, note down additional points, go to R.A.T.S and again go back to your book. That should be the modus operandi. Again, as I am taking the class, open your book and follow it. It is not necessary that the entire class will have to be listened to. You can stop anywhere, go complete the topic and again come back, because quite a lot of topics are there in this. It is unlikely that the student will be knowing this thoroughly. This is a case of an ecchymosis, large, irregular, map-like area of bleeding. So these are the terminologies that are commonly associated with bleeding disorders. A few more shall be there, which we shall be seeing. Bleeding disorders can be divided into platelet disorders, clotting factor deficiencies, vascular disorders, or disseminated intravascular coagulation. We should know exactly where the question falls. This is a structure of the megakaryoblast. So I find that it is having less of nucleus or lobations, called as hypolobated, whereas it is normolobated. Whereas in the case of a normal megakaryocyte, it is a large cell. In fact, it is the largest cell, which is having multiple lobed nucleus. These are some of the factors that help in megakaryopoiesis. We need not go through the text of this. This is a very important diagram because of platelets. This is important in various cases. Platelet by itself need not be asked as a question, but can be as an MCQ. But for ITP or anything, if you mention the platelet, you are good enough. So these are the various structures. I would like you people to go through the membrane, the canalicular system, and the skeleton, the dense granules, etc. These are there. They are the alpha granules and the dense granules, which are useful. If you people can mention this much, it is more than enough. So the structure of the platelets and the names, the whole letters alone, remember for the time being. Thrombocytopenia. Thrombocytopenia means there is a decrease in the platelet count. The normal platelet count is 1.5 to 4.5 lakhs. When it is less than 1.5 lakhs, it is called thrombocytopenia. When it is less than 1 lakh, we call it as moderate. When it is less than 50,000, it is supposed to be severe. And your books say that even a count of 20,000 platelets can prevent spontaneous bleeding. So when a patient is having spontaneous bleeding, that means there is an alarmingly low platelet count. Whatever be it, what are the causes for thrombocytopenia? It can be because of increased destruction. These are all the causes. So remember these. And of late, the dengue fever is one of the causes. Decreased production, as we had seen in a case of aplastic anemia or Fanconi's anemia. Radiation, chemotherapy, etc. Dilution, when multiple transfusions are given. And there is another condition called hypersplenism, where the spleen is very active, it phagocytoses. So these causes for thrombocytopenia we shall be having in our mind. We have seen the structure of the platelet, what the megakaryocyte looks like, what are the causes for thrombocytopenia, and what is the count. This is your age-old friend, the clotting cascade. So in this, you have got the intrinsic pathway and the extrinsic pathway, which you people would have already memorized in physiology, you will be knowing 12, 12A, 11, 11A, 9, 9A, etc. So these are the things. Now there is something called the intrinsic pathway. There is an extrinsic pathway, and lower down there is something called a common pathway. So when we assess a patient with bleeding, we must know where exactly the fault is. Is it here or in this region? So that will be of great importance. This is just for a recapitulation. And after a clot is formed, it cannot remain there. It has to be dissolved and digested. So you have got a fibrinolytic mechanism. So plasminogen to plasmin, fibrin degradation products. So this FDP, it is important in another sense because in some diseases, there will be an increase in the FDP or the fibrin degradation product, as we shall be seeing. So have this also in a corner of your mind. These can be more useful in a question on thrombogenesis. And this is the list of the clotting factors which you people already know, can again go through. Unlikely to be asked as questions, but definitely we should know. There is a purpura. You find that there are bleeding spots of a few millimeters and they are found widely dispersed in the skin. It can be because of vasculitis, which can again be because of immunological causes. One being henox-Conlin purpura. In one of the universities, this has been asked as a question, a very short question. So vasculitis because of immunological reason, purpura. That is henox-Conlin purpura. This is a very, very, very important flow diagram which you people will have to memorize. So I find that there are multiple things in this, as a result of which I should be able to explain. So there is an autoimmunity. You find antiplatelet antibodies are there. There is something called as opsonization, and there is also a suppression of the platelet precursor and the megakaryocytes. So there is a thrombocytopenia that is being produced. Also, you find that there will be a decreased lifespan in the blood, as a result of which you find there is thrombocytopenia. I would like you people to kindly go through this. And patient presents with severe bleeding manifestations. So this will be the stem of the answer in ITP. Idiopathic or immunological thrombocytopenic purpura, which is an essay question for you people. It can be a short note also. When this comes as a short note, it is the speed with which you answer that matters. Kindly memorize. So I have given a note of this. I would like you people to kindly go through. So what is the pathogenesis? There are the antibodies over here. It is a kind of autoimmune disorder over here. And in acute, you find it is of a low duration, and in chronic, it is of a longer duration. What can be the precipitating factors I have mentioned? This is important. So there is a platelet and it is sensitized with, there is an antigen that is over here, and as a result of which you find that there are specific antibodies, anti-platelet antibodies, which are produced and they get bound to these antigens. Now, what is supposed to have been a plain platelet is coated with these antibodies. Now, when these are there are some receptors in a macrophage, particularly in the spleen, which will adhere to the antibodies. Therefore, the platelets cannot escape. It is as though there are some tentacles around it and it is being devoured or eaten. Therefore, there is a reduction in the platelets. Why? Because of the sensitization, there are antibodies or immunoglobulins, and these get attached to the macrophages and there is phagocytosis. Preparing a cell for phagocytosis is called as opsonization. So this will be the pathogenesis, a must draw diagram. The previous flow diagram and this will complete 50% of the answer for us. And there is something called as chronic ITP, and acute ITP. So I would like you people to kindly memorize this. The flow diagram, or rather the tabular column that I had given. So what are the features in acute and in chronic? Memorize. Both the questions you can answer. Whatever be the question, you can write this tabular column. And chronic ITP, what is the thing? You find that there is a duration, usually it occurs in adults, and females are more than male. Any of the autoimmune disorders, you find that females will be more affected than males. Take the case of Hashimoto's, for example. Patient can be presenting with this kind of bleeding over there. And in the peripheral blood, there can be loss, because of which there can be reduction in the hemoglobin. Platelet count is being reduced. So when it is severe, it is less than 20,000, moderate around 50,000, and when it is mild, it is more than a lakh. So usually you have moderate or severe thrombocytopenia. And the other causes should be given as a differential diagnosis. And when you come to the bone marrow, there are a lot of other things, but megakaryocytes or the megakaryopoiesis must be described. Multiple myeloma, plasma cells. So here what will happen is, because of a reaction, there is an increased production of the megakaryocytes. There can be immature megakaryocytes or even megakaryoplasts, which less of budding of the nucleus. Classical, the moment you keep a bone marrow, we will not miss the diagnosis. Peripheral blood, no platelets. Bone marrow full of megakaryocytes. That is the diagnosis for it. And these are the antibodies, and what are the investigations. What can be the other changes? Bleeding, it can be throughout, etc. And the differential diagnosis you people can mention. When it comes to the platelets, there are two types of diseases. One is the count is reduced. In another one, I find that the function is reduced. This is the, kindly follow this description. This is a blood vessel. This cell is the endothelium, and this is the subendothelial collagen. And whenever there is a damage to the endothelium, there is an exposure of the von Willebrand's factor. It is normally present in our body. So there will be some receptors, and then the platelets get adhered to it because of the receptors. You should know the names of the receptors for you. So it will be glycoprotein 1b, and there will be another one called as glycoprotein 2b3. So once it is attached, it is called as adhesion, and the others become active, and more platelets get attached. That is called aggregation. So this is the normal function that happens. But in some diseases, I find that the platelets are very large. This is a RBC. This is larger than that, but then it is a platelet, nobody will believe. It is called a giant platelet. So such platelets are functionally not efficient, defunct. So this is the important diagram over here. Von Willebrand's disease. I would like you people to kindly follow my class, the text that I had given, and Robbins can be the best prototype for the von Willebrand's disease and hemophilia put together. Beautifully he has described, which I have also represented in my diagrams. Again, look at this one. So this is the subendothelial collagen. This is the endothelial cell. So there is a damage to the endothelium. Exposure of the von Willebrand's factor. And you find that glycoprotein 1b. There are the receptors over here, they get attached. And once it is attached, there is an activation of more platelets. This is called aggregation. Very simple. Dear students, look at this diagram very carefully. What all are we seeing over here? There is endothelium, absence of endothelium, exposure of von Willebrand's factor. Also, I find in the blood the factor 8. So factor 8 is becoming factor 8A, activated. And that is proceeding to produce fibrin. Two things. Absence of von Willebrand's factor or defect in factor VIII can produce bleeding. Also look at this one. This is a normal platelet. It has got certain substances called as glycoprotein 1b, or that can be the glycoprotein 2b to 3a. These are all there in the platelet. Secondly, I find that the platelets are becoming star-shaped, which means they are activated. So once there is an injury, there is an exposure of the von Willebrand's factor, the platelets are activated, the factor VIII, 8A leads to the formation of fibrin and a clot is being formed. This is the normal function. Now what will happen if the patient is having a defect in factor von Willebrand? You find that there will be bleeding. If there is a deficiency of factor VIII, there will be bleeding. Therefore, this particular diagram we can draw for both purposes. Hemophilia as a question, von Willebrand's disease as a question. That is exactly what Robbins will be describing in his text. So this is the von Willebrand's factor and it is described as a complex over here. I would like you people to just read it if possible. What are the different types of von Willebrand's disease? What can be the clinical presentation? Excessive bleeding during wounds, during menorrhagia, etc. or bleeding from the gums. And in any of these bleeding disorders, please note that patient will be having bleeding from multiple sites, not a single site. And the lab diagnosis will be these. So these are the tests I would like you, that is why I have enlarged this. I would like you people to kindly by heart the lab diagnosis of von Willebrand's disease. The bleeding time is prolonged, APTT is abnormal, and there is an abnormal prostacyclin aggregation test. So this is one. The treatment will be desmopressin that is given. And also factor VIII can be given in high doses. This will be the treatment. The next question will be hemophilia. Hemophilia is an X-linked disorder. This is the mode of inheritance. So there is the father who is unaffected, mother who is the carrier. And then they have got children. I find that the one son is unaffected, whereas another son is totally affected. And the daughter will be a carrier or will be unaffected, which means 25% of the children, and the patient will be a male person. So females are carriers, males are sufferers. That will be the dictum in any X-linked disorder. This is only for the severity. You people need not by heart this table. And this will be the presentation, etc. So what is the incidence, X-linked disorder, etc. All are given over here. And what can be the clinical presentation? For example, haemarthrosis, weight-bearing joints, etc. There will be abnormality. And what are the lab investigations? This again I should write. Hemophilia, factor VIII is deficient. Therefore, factor VIII has APTT. Platelet count will be normal. It is not a thrombocytopenia. Bleeding time will be normal. Now, these are the differential diagnoses. So, quite simple, one page. Just remember, but 200 times it has been asked as university question. And this is the classical haemarthrosis. That is over here. Also, there is another disease called the Christmas disease. That also you people shall read up in your text. So hemophilia is one, then Christmas disease, and what are all the things? What is the treatment that can be given? Sometimes they give what is called as pooled plasma. Plasma from multiple donors are taken and is transfused, and that can lead to infections as a complication. So that will be about hemophilia. This is one important question called as disseminated intravascular coagulation. A deadly question which students will fumble. So in this one, these are the features. Kindly go through this flow diagram repeatedly. So there can be sepsis. That is what I am seeing over here. It is a case of meningococcal septicemia, which can be given as a history. And there will be endothelial injury. Lot of clotting factors are consumed. Therefore, it is also called consumption coagulopathy. So the platelets are consumed. Therefore, there will be bleeding, as a result of which there can be a thrombus formation also, aggregation of the platelets thrombus, which will lead to ischemia. Also, there will be lysis and bleeding. Simultaneously, the patient will be having multiple areas of bleeding as well as clotting. That is why it is called as consumption coagulopathy or disseminated intravascular coagulation. So that is the definition over here. And there can be microthrombi. These are the names for it. Remember the 7 M's. It is my mnemonic. So this you people can memorize as the predisposing conditions for DIs. Major surgery, for example, meningococcal, malaria, etc. Please read this up. Pathogenesis I have explained earlier. And what are the tests for it? You will be finding this fibrin degradation product and D-dimer. These two are positive. Other things are not very classical. And what are the organ changes? I find that there will be multiple thrombi and then there will be infarct, as a result of which there will be necrosis in the organs. Investigations I had mentioned. So what you people should see will be all these things. So a classical, a good diagram is over here. I would like you people to kindly see this one. You'll have to look for the clinical history. Platelets will be reduced. RBCs will be fragmented. PT and APTT are prolonged. Low fibrinogen levels. And these tests will be positive. FDP and D-dimer. And this is a glomerulus, the kidney, in which I'm finding thrombi leading to necrosis. And this is a summary of the differential diagnosis in bleeding disorders. So important diseases for us can be von Willebrand's disease, hemophilia, it can be Christmas disease, DAC, and it can be IT. These are the common investigations. By heart the investigations, and you will definitely be able to write it. Not very difficult. For example, this is factor 8. When you do a factor 8 assay, there will be a reduction in hemophilia, not reduced in any other condition. Factor 9, reduced in Christmas disease, not reduced in any other condition. And von Willebrand's factor, it is reduced in von Willebrand's disease. And restocytin, etc., it is abnormal in von Willebrand's, not elsewhere. When it comes to platelet count, everywhere it is normal, but reduced in a case of ITP and also in DIs. So this particular chart is easy for you to memorize. It will help you answer most of the MCQs as well as a summary of the bleeding disorders. So there's a quote that I took. Always I have some amount of quotes that will help me. People will stab you in the back and then ask you why you are bleeding. We shall continue with the healing for the exams in the next class. Thank you.